Great. Thank you for having me, and welcome everybody to this. Hopefully you find it helpful. And what I'll do is we have about an hour. I'll try to move through my slides fairly quickly. If there's somebody who has something that wants to stop me, it may be a little tricky, but feel free to try. And we can talk about whatever question you have. But we should have about 10 or 15 minutes at the end to get some questions in as well. And I think, even though this isn't CME, oh, that's not good. Oh, okay, there we go. I don't have any conflicts to talk about. So venous disorders, as you know, come in many different kind of categorizations, but we might call them in two flavors. We might discuss them as acute venous disorders, so VTE, DVT, PE, and superficial phlebitis, and then well, maybe three flavors, sorry, congenital forms, and then the chronic forms. And we're going to spend this session talking about chronic venous disorders of the lower extremity. So this slide sort of summarizes the extent of the type of problems that we're going to see, and the majority of the patients that I end up taking care of fall into this category right here. The patients can present with more extensive or advanced changes, and we'll talk a little bit about a categorization available to from a physician's point of view, grade the level of venous insufficiency. Certainly, IRs are perfectly positioned to be involved in the care of patients with chronic venous disorders. We're very good at, with a little training, can be very good at all of the elements that are in this top category, and are facile in doing a lot of the deep vein work that's required for taking care of chronic venous disorders, and are poised to be available to contribute when things like artificial valves are available. So this is something that we can do completely. It's not something that we need anybody else to refer us patients. We don't need to get anybody's help to do part of the procedures or different parts. So this is a great place for young IRs to develop and to get into, because it is something that we can participate in all aspects of care. So I'm going to talk about, with regard to your particular audience today, chronic venous disorders, but I'm going to concentrate mostly on the superficial disorders, as you'll hear. And I'm going to talk about the anatomy, the physiology, how we examine patients with duplex ultrasound, a quick introduction to classification, and also a quick introduction to treatment, and then we'll open it up for questions. So most of you are extremely familiar with the deep venous system. It's something that we talk a lot about in radiology. It's responsible for a lot of the blood return from the leg, and it's responsible for the great majority of the acute venous morbidity. More than 90% of lower extremity thrombosis events are acute deep vein thrombosis rather than superficial phlebitis. The superficial venous system is a little less familiar to the radiology community, but it's responsible for over 90% of the chronic venous morbidity. So this is the bottom of that pyramid. We see in many practices the tip of the iceberg with the deep vein problems, but it's the superficial vein problems that account for the majority of the clinical sequelae. So thinking about veins, how do you categorize superficial from deep? Well, this is the muscular fascia that I'm toggling. I think you can see my pointer. Claire, can you see my pointer? Oh, well, here's my pointer. I think you can see my pointer. This is the superficial. Excellent. And so this is the division between the deep compartment and the superficial compartment. Superficial veins are generally outside the muscular fascia, and the deep veins are deep to the muscular fascia. In general, the superficial veins drain to the deep veins at the saphenofemoral junction, the saphenopopliteal junction, and through innumerable perforating veins. Here's a schematic drawing of the superficial venous anatomy that's of pertinence to today's lecture. The great saphenous vein on our left and the small saphenous vein system on our right. The great saphenous vein is very conspicuous in many patients in front of the medial malleolus, and then runs up the inside of the thigh to drain into the femoral vein. And it has two important tributaries in the calf and 2 important tributaries in the thigh, and then some tributaries up near the junction. The small saphenous vein begins along the lateral aspect of the ankle and then comes up foot and ankle, and then comes up the posterior aspect of the leg. In about 2/3 of cases, there's a connection to the popliteal vein. In about 1/3 of cases, there isn't a connection, or maybe let's say 20% of the cases, there isn't a connection to the popliteal vein, and the vein continues up into the posterior thigh. Many times that connection to the posterior thigh exists, and if you look carefully, you can find it in just about everybody. It may not be well developed, but it's there. In some patients, this thigh extension or cephalad extension of the small saphenous vein terminates into the deep system via a perforator in the back of the thigh. And in some other patients, it extends all the way up to the posterior circumflex vein of the thigh to drain into the GFV. When it does that, the name of the vein that connects the small saphenous to the great saphenous is known as the vein of Giacomini. Recognize that we're using the term great and small. All other terms have been abandoned because they're confusing by international consensus, and that's the point of this particular slide. When we look at the anatomy of the veins in cross-section, this is particularly pertinent to ultrasound. We'll see that the saphenous veins don't live truly in the superficial space, but rather in their own unique space called the saphenous space. The muscular fascia splits into 2 parts, into a superficial and a deep fascia, and the saphenous vein lives inside that compartment created by that split. Kind of has an eye, Cleopatra's eye-like look, or a Seattle Seahawks eye-like look, both for the great saphenous vein and for the small saphenous vein, as you can see in the lower picture. Veins that are outside the fascia are not technically saphenous veins, but some veins do have the term saphenous that exists for them when they're outside, or one particular vein does, that is used to label a vein when it runs outside the fascia, and that specific vein is called the superficial accessory saphenous vein. And this drawing kind of shows you in a case where the superficial accessory great saphenous vein may be incompetent. This is a cross-section at this level and a cross-section at that level. And here you have the great saphenous vein coming down, and then reflux spills into a vein that runs parallel to the great saphenous vein, but just outside the sheath. And that would be the definition of an accessory saphenous vein, or superficial accessory saphenous vein, as demonstrated in this particular case. Here you have the great saphenous vein, which is enlarged and refluxing. Here you have a smaller great saphenous vein that is competent, and the superficial accessory great saphenous vein is incompetent. And you can see the same thing here. Veins in this space are the saphenous veins, the true great saphenous and small saphenous veins. Veins out here are tributary veins. If that vein, or if one of those veins happens to run parallel to the great saphenous vein outside the sheath, that has the name superficial accessory great saphenous vein. Here's an example of varicosities in the superficial accessory saphenous vein between point A and point B. That vein has become varicose and redundant. We talked a little bit about the cranial extension of the small saphenous vein. When looking at this diagram, here's the sagittal image. Looking at the small, head is to the left, looking at the small saphenous vein as it goes into the popliteal vein. Gastrocnemius veins can, but not always, join into the small saphenous vein, but frequently there's a cephalad extension heading up into the thigh. It may be very small, but it's usually there. Perforating veins are important veins that communicate between the deep and the superficial veins, and technically are part of the deep system. We used to refer to them by the eponyms that were very common and seen on these diagrams, but we try to get away from those now and to try to use topographically or location-based nomenclature that identifies the names of the perforating veins. Some of the important perforating veins in regard to the development of varicose veins are in the medial thigh, the lateral thigh, or in the popliteal fossa. Some other perforating veins, which are relatively commonly discussed as part of the pathophysiology, are paratibial veins and posterior tibial veins, and we'll talk a little bit about that later, but you'll see them here. Somebody on the talk has
Yeah?
with their, or somebody online has a microphone on, and we should probably mute it. I hear them speaking to their children.
Can everyone please make sure if you just signed on to mute your microphone because we're getting a lot of static.
We talked a little bit about the deep veins being inside the muscular compartment. One of the things that happens when they're inside the muscular compartment is these veins are exposed to the high pressures of the muscular compartment that occur with calf muscle contraction or muscle contraction. Those veins that exist in the soleus vein or soleus muscle and the gastrocnemius muscles, which Dr. Netter did not draw for us, the gastrocnemius and soleus veins, are these big capacious thin wall veins that collect blood when we're sitting and standing without moving. And when we contract our calf muscles, those are essentially the chambers of the, if you can consider the heart of your leg or the heart of your venous system, that are the chambers upon which these calf muscles contract to push blood back up toward the heart. They function, these veins inside the soleus muscles and gastrocnemius muscles in particular function as venous reservoirs and pumping chambers for this peripheral heart. There are valves that let blood fill into these capacious veins and valves that control the blood flow from the feet toward the heart against gravity with calf muscle contractions, and that's really the physiology of the return of blood from the calf back up to the heart, the so-called musculovenous calf pump or peripheral heart. On the right, you'll see a diagram that shows that in action with inlet valves and outlet valves opening and closing at the appropriate time to allow blood to propel its way back up from the bottom of the body to the top of the body against gravity. So chronic venous disorders are caused by venous hypertension. That's the currency for all the problems related to venous disorders. Venous reflux is the most common cause, and overwhelmingly, the venous reflux occurs in the superficial rather than the deep compartment. So we're going to spend a lot of time talking about that. Deep vein reflux is certainly present and is responsible for problems in some patients. Obstruction from a prior DVT or obstruction from a compression of a pelvic, an iliac vein from either an iliac artery or some mass in the pelvis could also cause chronic venous hypertension. Pump dysfunction, either neuromuscular or purely muscular, can lead to venous hypertension because you can't pump the blood out of your leg to reduce the pressure. And then there's some congenital causes of venous hypertension, which we're not going to really get into today. So the chicken or the egg story is the problem a problem with the valve, or is it a problem with the vein wall? And although it's not completely worked out, it seems as though the evidence points to the problem being in the vein wall that causes the vein wall to dilate and then ultimately leads to valvular dysfunction. And so, again, it's not really clear where the problem begins, and the pathophysiology is only partially worked out, but it seems to be a vein wall problem rather than a vein valve problem, as has always been described. The physiology of venous return the physiology of superficial venous insufficiency is very much like the physiology of mitral valve regurgitation. It can be mathematically modeled similarly. A certain amount of blood is pushed up the deep system toward the saphenofemoral junction, in the case of saphenofemoral junction GSV reflux, and then a fraction of that falls back down or leaks back down and falls down through varicose tributaries and eventually re-enters the deep system through re-entry perforating veins and then goes up. So you might have 1.1 times the arterial blood flow of the leg coming up the femoral vein, and then let's just say 10% of it falling back down the superficial incompetent pathway to ultimately fill the varicose veins. So you can think about the physiology in that way. When we look at causes for venous insufficiency in patients, about saphenous reflux is responsible for 5/6 of all patients with varicose veins. 2/3 of the patients are related to great saphenous vein reflux, and about a sixth of the patients with varicose veins have small saphenous vein reflux. And there are a variety of patterns that you could see. As I mentioned, great saphenous vein reflux originating at saphenofemoral junction is relatively common. Sometimes it skips segments. So here's an example of great saphenous vein reflux falling down into and out into some tributaries into the thigh that become varicose. The veins under the skin can't handle the pressure and volume as well as the veins in the saphenous space. But then the reflux spills back into the great saphenous vein and goes all the way down to the ankle and causes ankle varicosities. You can also have non-saphenofemoral junction causes of GSV reflux. Here, a mid-thigh incompetent perforator. And here, external pudendal varicose veins from pelvic venous insufficiency, which I think is a better term than pelvic congestion. And I think I would suggest that you use that term in the future. Small saphenous vein reflux can come from saphenopopliteal junction incompetence, or it can come from incompetence of the thigh extension of the small saphenous vein. Incompetent perforators in the posterior thigh can do it, or even as diagrammed in this particular case, some varicose veins that are coming from the external pudendal system can drain into the thigh extension and then into the small saphenous vein and cause small saphenous vein varicosities. We can have non-saphenous causes of saphenofemoral junction, varicose veins. And here's an example of a patient with external pelvic or external pudendal varicose veins, again, pelvic derived, that lead directly to varicose veins. And here's a patient with incompetent mid-thigh perforator leading directly to varicose veins. So ultrasound really was the big coup in the last few years in terms of making venous treatment so much better. You know, we can talk about laser, we can talk about all the other stuff that's come out, but really it's been ultrasound. And ultrasound has led to our ability to understand what we're treating, and understand the anatomy and the physiology, but it's also helped us now to direct our therapy. And it's shown us that not everybody has just one pathway of problem. There may be saphenous reflux, pudendal vein reflux, and then a perforating vein in the same patient. And so we can understand why perhaps the prior generation of doctors who took care of patients with veins without ultrasound to help them were frustrated, and their patients were frustrated because their, quote, veins didn't go away. And it was really a function of not really being able to figure out what's going on. When we do the ultrasound of the patients with, when we're looking at superficial venous insufficiency, we like to do them standing, although a reverse Trendelenburg position is certainly reasonable. And we start examining them up by the saphenofemoral junction. We work our way down to the calf, and we use a position much like what you see here with the leg turned outward, so we can see the inside of the leg very well, and then periodically compress the calf when we need to look for reflux. A normal vein, a normal GSV, is small. Usually an enlarged GSV is related to reflux, but that's not always true. And so you can't use size to determine whether something is normal or abnormal as an absolute. When we follow these veins, we do look at the size periodically. It does give us some ideas of what's going on. Many times when you follow the vein, the GSV downward, when it spills into the last of the big tributary veins that are refluxing, its caliber will get much smaller below that level. And that'll give you a clue to what you're looking at. And it's very good to follow the relationship of the saphenous vein to the varicose veins, and then periodically to examine it with color Doppler and pulse wave Doppler. And we'll talk a little bit about that in a second. The small saphenous vein and the posterior thigh and all its thigh extensions are examined by looking at the patient from the back and doing the same basic type of exam, and we'll talk about that in just a second. And all the same types of things that we talked about with the great saphenous vein are what we're looking for when we look at the small saphenous vein and its system. Again, we talked about the great and small saphenous veins as being intrafascial, and here's an example of a great saphenous vein in its sheath. Here's an example of the small saphenous vein in its sheath here at the level of the gastrocnemius veins and here at the level of the soleus veins. We talked a little bit about the thigh extension, and here's an example of enlarged refluxing patient, and this is an enlarged vein on the posterior aspect of the thigh, and you can see it lives in a similar kind of position as this great saphenous and small saphenous vein do. Color is an extremely efficient way for looking for reflux, and pulse wave is an excellent way to document the duration of the reflux in general. A venous closure time in superficial veins longer than 0.5 seconds qualifies as reflux, although in most patients it's not 0.6 or 0.7, it's like 5 seconds, 8 seconds, 10 seconds. So these are certainly useful criteria, certainly for reporting purposes for medical literature, but in general we're looking at seconds of reflux. This is generally how we insonate for reflux. We'll grab the ankle or grab the calf muscles where the veins are that are collecting the blood, and then we'll look at whatever segment we're interested in with Doppler. We'll squeeze, and generally ultrasounds are set up the way these are, with blood flow toward the heart as down and blood flow toward the feet as up on a velocity time curve. And so when we squeeze, we'll be pushing blood up toward the heart with a certain amount of velocity, and we let go in a normal patient. There's no retrograde flow back toward the probe or up on this scale. However, in patients with venous reflux, when we squeeze and then we let go, then there's going to be velocity going in the wrong direction toward the feet, and then that wrong direction will continue for a certain amount of time afterwards. The reason that this is the convention for ultrasound is that ultrasound of the arteries was done before the ultrasound of veins historically, and it was the convention to just leave the pulse wave Doppler settings the same for both. One thing that I see, this slide is not exactly where I ideally would have put it, but part of what our analysis will be is to look at the common femoral vein and the popliteal vein when we're looking for reflux in addition to the great saphenous and small saphenous veins in multiple locations. And the reason we look at the deep system is to look for deep vein reflux, but we look at the common femoral vein waveform to also infer any particular obstructive problem that may exist above the inguinal ligament. So if you have an iliac vein occlusion, either intrinsically from an old DVT or extrinsically from compression, what happens is you lose the normal respiratory variation that occurs in the blood flow in the common femoral vein, which is most evident in the supine position, although you can see it in the standing position too. So usually there's an inspiration and expiration variability. You'll also see reflected cardiac pulsations in the common femoral vein in a normal pathway between the common femoral vein and the heart, where pulses can be, or waves can be transmitted back and forth along that conduit. However, when that conduit is compressed, you'll get a continuous low-level venous hum, so to speak, in the common femoral vein that particularly when it's asymmetric to the other side, will be a clue to the fact that there's an outflow vein problem that needs to be at least considered further. Chronic venous disorders are incredibly common. 50% of adults have some venous disease, so it's something that's in all of, or at least half of our futures, I guess. Varicose veins are more common in younger women than in younger men, but by time patients get into their 70s and 80s, it evens out. And as it turns out, men tend to have the more severe versions of venous disorders. When we look at the prevalence of this disease, it is extremely high. Look at it compared to peripheral arterial disease. So we're looking at a 5 million versus a 25 million difference. This is why there's such interest in caring for patients here, because in many ways it's really hard to get into turf wars because there's just so many patients out there. There probably aren't enough of us to take care of all the patients that need to be taken care of with vein disease. Vein disease increases with age, increases with parity in women. It increases in patients with standing and sitting occupations, and it increases in patients with BMI above 25. There's certainly a very strong family history to this, and although we don't really know the absolute genetics, but it's probably some sort of autosomal dominant inheritance with variable penetrance. I'm sort of bouncing around. I reorganized the talk just so I can make sure I could get some things in that I didn't get in with my residents. I just wanted to let you know that there are different ways of categorizing venous disorders. They can be categorized by physician-reported scales, and they can also be categorized by patient-reported scales. Patient-reported scales are getting a lot of traction. The government, many of the insurance carriers, and physicians, rightly, are now caring more about what patients think about how their treatment affects them, rather than how we think it works using a variety of surrogate endpoints. And so I bring this in just to make your awareness higher for the patient-reported outcome approach to the care of patients, particularly with quality of life type problems rather than duration of life type problems. A very commonly used language to classify patients has the acronym SEEP. The SEEP comes from the fact that it looks at the clinical cause, the etiology of the anatomy, and the pathophysiology of a given particular problem. Although these are important, particularly in literature reporting, in practice, most doctors will use the clinical or C component of the SEEP classification, and I think it's common enough that all of you should become aware of this particular categorization for superficial veins and for deep veins, although there are the Villalta scales and the VCSS scales that I'm not getting into that are also important. So what you can see, it's a continuum from normal, C0, to active ulcers, C6. Most of the patients that I'm taking care of are in the C1 through C4 area, but if you're involved in caring of patients that come from wound centers, you'll see a lot more of the advanced C5 and C6 disease patients. Here's an example of an advanced C4B type problem. This is lipodermatosclerosis. The skin and the subcutaneous fat have become sclerotic from the effects of chronic venous hypertension, and the skin starts to cicatrize down. This becomes really hard. There's really no plasticity to the leg, and eventually the leg starts to hourglass in. So when you see this, these are very classic findings of chronic venous hypertension. I mentioned another scale. It's called the Venous Clinical Severity Score, and it's a very much promoted scale that's going to get a lot of traction in both the superficial and deep worlds for taking care or classifying patients. It's a physician-generated scale, and it uses a variety of attributes. There are 10 of them, actually, and then 4 levels of classification. And so you can either have a score of 0 or you can have a maximum score of 30, and that's one way to classify patients. So here's an example of a patient with pain and varicose veins, and this is how the classification system would work. Occasional pain, moderate varicose veins in the calf or thigh, and venous edema above the ankle but below the knee. So VCSS score of 6, and wears compression and still has these symptoms most days. And here's what happened to the patient after treatment. The VCSS score went down to 3. So this is a very dynamic scale. You might argue that the patient still has a few varicose veins, so they went from being a C2 varicose vein and edema C3 patients, so they were C2 and C3 before, and now maybe they're just C2. But this VCSS score is much more dynamic, and it has a lot more flexibility in terms of tracking patients through the course of their therapy. It is biased toward advanced disease, and it does perhaps not discriminate as well in the minor or lesser forms of venous disease as a criticism, but it's a scale that's out there. Again, bouncing around just a little bit, I apologize, but when we do treatment, we're not doing it just for cosmetic causes, because many of these patients have symptoms. So we've already looked at some of the dermatologic problems, but pigmentation, eczema, lipodermatosclerosis, and ulceration can be complications of venous hypertension long-standing. But the most common things we hear from patients, and they're really common symptoms, are that they have throbbing, aching, heaviness, fatigue, worse at the end of the day, worse after a busy day standing, better when they elevate their legs, and in many cases better when they're putting their support stockings on. So when we treat varicose veins, what are we doing? So we're looking to reduce the venous hypertension. And so with our ultrasound exam, we've looked for saphenous vein reflux, and if we find it, we're going to want to treat that first. When that's completed, or if that didn't really exist in the first place, then we can move to step 2, which is to get rid of the varicose veins directly, either with sclerotherapy or microflebectomy. So years ago, patients were very intimidated by treatment for veins. It got a really bad reputation, and here's a diagram that sort of makes that point. And so patients were pretty intimidated about treatment. But nowadays and also because the veins just didn't get better. And as I pointed out, to some extent, that was related to difficulties in making diagnosis in the absence of ultrasound. But it also had to do with the fact that ligation and stripping had a relatively high recurrence rate in spite of it being done well. We talk about ultrasound as being the great advance, but there's no question that minimally invasive treatment has not only made patient acceptance of vein care better, but doctor acceptance as well, because it's office-based. It really doesn't need any sedation at all. Patients are up and about pretty quickly. There's very little downtime, and the outcomes are very cosmetically pleasing. So the first big advance in vein care was ultrasound. The other big advance was more minimally invasive approaches to closing the saphenous vein. Sclerotherapy had been used to try to close the saphenous vein for many years, and it didn't work as well as people had hoped, but it would work maybe 75, 80% of the time if you treat veins 2 or 3 times, but sometimes the veins reopen. But when heat started to be used to close the saphenous veins, the success rate went up into the high 90s, and the durability at 1 year went up into the high 90s. These heat-based therapies to seal close the saphenous vein are outpatient, local anesthetic procedures that have become extremely popular and are basically replaced ligation and stripping internationally. Here's an example of a patient getting an endovenous laser ablation, but to some extent, radiofrequency ablation, which is the other main U.S. heat-based therapy, is not that dissimilar. You figure out, and this is Dr. Min here, but I took some photographs of him, or actually a video, and I took some still shots out of that video to make this point. So you'll figure out which segment of the vein you want to treat, and generally you want to treat the entire refluxing saphenous system that exists. And so in this particular case, the segment was marked. If you have, as I showed you before, a refluxing segment, varicose veins going off into, or reflux spilling out into tributary varicose veins, and then another refluxing segment, for durability, filling another set of varicose veins. For durability, there may be a lot of value in treating this segment in addition to this segment. So you don't want to just treat from A to the saphenophrenic junction, but you at least want to consider treating from C to the saphenophrenic junction. If C occurs in the mid-calf or higher, I think it's kind of a no-brainer. If C goes all the way down, or if the reflux goes all the way down to the ankle, you need to recognize that there's this chance of developing with thermal-based therapies paresthesias of the the saphenous nerve, which lives very close to the saphenous vein in the mid and lower third of the calf. But that's for another day. So now we've got the vein marked and we're sterilely prepped and draped. We use a micropuncture or some sort of ultrasound-guided access of the saphenous vein, and then we place a sheath. And through that sheath, in this particular case, we're placing a laser. And this is an old generation laser, but nonetheless makes the point. And then in these heat-based therapies, we usually start at a certain point a little bit downstream from the saphenophrenic junction in patients with GSV, saphenophrenic junction incompetence. And here's the tip of the laser. We probably would pull it down just a little bit more, but just below the superficial epigastric vein, which was one of those 3 junctional veins that I alluded to in my original diagram that occur just before the GSV go into the femoral vein. And then once we have the laser in place, and here's another example of the laser fiber or radiofrequency fiber in place, just below the saphenofemoral junction, then what we need to do is surround the vein with local anesthetic. And here is a needle and a syringe injecting the local anesthetic. So here's a picture of the great saphenous vein before tumescent anesthetic is applied. It's just a fancy word for the local anesthetic that's very dilute and high volume. And then here it is after the tumescent anesthetic is provided, where there's a halo of protective fluid around the vein, and the vein is crunched down on the thermal device so that there's good heat transfer. So not only does this numb, but it also serves as a compressor of the vein and a sort of heat sink around the vein to absorb any energy. Here it's what it looks like in the longitudinal plane. And then we turn the laser fiber on and slowly withdraw it back through the vein. We usually go for about 100 joules per centimeter to try to close these veins with really high success rates, using a 14 watt continuous mode laser at 810 nanometers. So all of these features go into the determination of the dose, a little bit beyond the scope of this topic, but I thought I'd throw all those terms out there so you understood what I was talking about. Betadine is wiped after the laser is done. Here's the little skin nick through which the laser was inserted. We put a little gauze pad on there, support stocking, and send the patient out. A little look at the data for the great saphenous vein. The range for laser is between 90 and 100%, depending on the duration of time that you look at these things. So here in our particular group with our first 500 patients, 17-month follow-up, 98% success rate. So it works pretty well, and it does so with very low complication rates. Here's some more data on the GSV and some data on the small saphenous vein, which I think works a little less well. Here's some data when you go out to the 36-month level. You can see they're closer to 90% success rates, and I think that's probably fair. Now, these are using the surrogate endpoint of flow in the small saphenous vein after treatment. There are patients who still have flow in the saphenous vein, but the flow is reduced, maybe the reflux is eliminated. Many of those patients, by patient-reported outcome strategies, would be clinical successes. But certainly, the surrogate endpoint is not something to ignore, and certainly may have some relevance to long-term durability. Here's using a radiofrequency device in an industry-sponsored registry at 4 years, looking at pain, fatigue, and edema pre-procedure. And at 4 years, you can see all of those elements get much better very quickly, and there's a great deal of durability in terms of managing those symptoms over time. So this is an example of patient-reported outcome data supporting the role of a specific treatment. So what do we look for in follow-up for these patients? I think this is important for you guys to kind of recognize. So after ablation at 1 month, we see a very thick-walled vein and a very small hypoechoic lumen. The smaller the better, that doesn't compress, that has no flow. This very thick-walled vein is an inflamed vein. I'd like to just sort of show you in contrast. This is an example of a thrombosed great saphenous vein. If you don't use enough energy, you don't push the vein close enough to the thermal device and get good tumescent compression of the vein may thrombose because it doesn't get enough of a dose, rather than eventually get sufficiently inflamed so that it'll scar down. And thrombosed veins can recanalize, and that's really this vein has flow around the central thrombosis that looks very much like a subacute thrombosis in any other blood vessel that you would look at. So what happens to the veins with time? So here's an old ultrasound showing the great saphenous vein before saphenous ablation, and then a year later you can't even find the vein. This is the anterior accessory great saphenous vein in front of the femoral vein, about 1 centimeter or 2 below the saphenofemoral junction. Here's the anterior accessory great saphenous vein in the same location. The great saphenous vein is gone. Generally, the vein diameter in a successfully treated patient is less than 2.5 millimeters at 6 months after laser. So that's actually a great thing to see. Here's an example of a patient 1 year after laser ablation of a fairly big saphenous vein, and there's this little tiny thing, this little scar left in the saphenous space. Complications, very low less than 1% DVT. We'll talk about that in a moment. Neuropathy, particularly when you go below the knee with the great saphenous vein, or below the gastrocnemius bellies and the small saphenous vein, because of the presence of the sural nerve adjacent to the small saphenous vein. The type of complications, thrombotic complications that it can occur are these so-called transjunctional extensions of clot from the saphenous vein into the deep system. So here's a thrombose rather than a probably optimally heated saphenous vein with thrombus poking into but not really doing too much to the femoral vein. The rate of this happening is about 1%. It's really rare to progress to an occlusive DVT, and generally all of these are asymptomatic and only found on surveillance ultrasound. Given the low rate of complications, some argue what's the value of surveillance ultrasound. And in general, we don't look for these problems at early follow-up, except if, for whatever reason, we're very concerned, perhaps in a hypercoagulable patient, someone who's had DVT before. One way to describe these transjunctional thromboses into the deep system is to call them, or to use the classification that's been termed the endovenous heat-induced thrombus or thrombosis, or EHIT. I'm not sure these are all heat-induced thromboses, but it is a heat procedure where it happens, so we'll go with that nomenclature for now. Again, this is relatively rare. The one I showed you before may have been somewhere between class 1 and class 2. Class 1 extends up to, but not into, the femoral vein from either, or the popliteal vein from either the saphenous vein, great saphenous vein rather, or small saphenous vein. And EHIT 2 is one that extends into the parent deep vein, but only occludes about 50% of the lumen. EHIT 3, more than 50% of the lumen, and EHIT 4 is an occlusive DVT. So here's an example of an EHIT 3. Here's a thrombosed great saphenous vein, and then thrombus extending on the sagittal image up into the great saphenous vein, almost occlusive, but not quite. Here's a transverse image of that thrombus in the femoral vein. This is what we don't want to see after thermal ablation of the saphenous vein. Another thing we don't want to see after thermal ablation of the saphenous vein is an AV fistula. So if you look at the sagittal view of the femoral and saphenous vein, in that sort of nutcracker position lies an artery that you can see right here. It's the superficial external pudendal artery, a branch of the common femoral artery that then goes medially, and it runs right in here. So if you overzealously poke with a needle in here, putting tumescent, as I sometimes feel like I might be doing because I'm trying to put so much around there, or if you have a laser fiber maybe pointed right there with not enough tumescent separating the vein from the artery, you could create an AV fistula between that artery and that vein. Here's another artery in the axial, the same artery in the axial projection, looking at that. Another place where this AV fistula can occur is at the sapheno-popliteal junction with one of the small branches of the popliteal artery that can run right along the small saphenous vein proximally. So you should look for that on your ultrasounds after any thermal ablation. So what do we do with the varicose veins now that we've gotten rid of the saphenous vein reflux, or if the saphenous vein reflux didn't exist in the first time? Well, I think for small and medium veins, sclerotherapy is the best approach. But even for large veins, you can do sclerotherapy. It just becomes more work and a little bit more challenging. For medium and large veins, microphlebectomy is a really good approach, and we'll talk about that. Both benefit the patient cosmetically and symptomatically. So microphlebectomy, also known as ambulatory phlebectomy, also known as stab phlebectomy, which I think patients probably would not like to hear, uses small skin nicks and hooks that look like this. These are Oish hooks. These are the ones I use. And you can remove pretty much all the veins. Here's an example of a patient's varicose veins that were marked. I usually mark them using transillumination just because veins decompress asymmetrically, and they shrink a lot when patients lie down. And so I think it's easier to get an accurate marking of them with them lying down. Then you inject tumescent anesthetic, again, the same stuff. This is 0.1% lidocaine, really dilute lidocaine. When you're doing your ports and your tunnel catheters, you don't need to be using 2% lidocaine. You could be using 0.1% lidocaine. When I started to figure that out, I used to inject a ton of very dilute local anesthetic, basically created my port pocket with the 0.1% lidocaine. Very tiny, 3 millimeter, 4 millimeters would be giant. The 3 millimeter skin nicks, put the hook under the skin, bring the vein up as a loop, and then divide it, pull in one direction, pull in the other from this point, and then go downstream and get maybe that you got about this much of the vein out, make another skin nick here, get this vein to that vein, go a little bit further downstream and make another nick and another nick, and you can get the entire vein segment out. Here's an example of a very large set of varicose veins, and here was how much vein I was getting out when we stopped to take a picture. I actually got maybe another 3 finger breaths of vein out before I decided I'm not pulling anymore, and I tied off that vein with a small, tiny bioabsorbable suture. Didn't need a suture on the skin because the skin nick was so small, and here's the guy maybe 2 months after the procedure, and you can see the difference after thermal ablation and microphobectomy. Sclerotherapy, the concept is you introduce a drug into the lumen of the vein that injures it in a way that it causes irreversible endothelial destruction. If it doesn't cause irreversible endothelial destruction and just thrombosis, maybe the dose wasn't enough, maybe the concentration or the amount of drug wasn't enough for that particular vein, the thrombosed vein can recanalize, and it's a procedural failure. You can use it on varicose veins, reticular veins, and spider veins. And again, you want fibrosis, you don't want thrombosis. A very classic set of veins, which almost always is a phenomenon seen in women, are these sort of lateral thigh arborizing patterns of spider veins that are related to reflux in the lateral venous system, a vestigial venous system that has nothing to do with the saphenous system. Usually these patients don't need ultrasound, and you can pretty much just tell them you can treat these very well with liquid sclerotherapy. In general, when you're treating spider veins, you're looking to treat the feeding veins first. So if there is saphenous reflux, you would get rid of that. Then you would get rid of the varicose veins. Then you would get rid of what we call these greenish reticular veins, and then inject the spider veins. Whether you do that all in one visit or on several visits is really a combination of dealer's choice and what the anatomy will allow you. Recognize that in the cross-section of the leg, you have the saphenous vein living in the saphenous space, connecting by perforators to the deep system. And then you have superficial veins in the superficial vein space, which can connect to the saphenous vein or can connect directly to the deep veins by perforators. And you have these small little veins that run just underneath the skin. They're small veins that feed or drain spider veins, or veins in the skin rather, and those are called reticular veins. And when you have reflux into the reticular veins, out into the spider veins, you get these sort of reticular spider vein complexes that are very rarely symptomatic, but very commonly aesthetically displeasing. If they have symptoms, they're generally pruritus, maybe a little bit of discomfort in some patients with larger reticular veins, but not something that's generally debilitating discomfort. So again, when you treat patients, and the slide isn't doing what it's supposed to do, but first you treat the varicose vein, then the reticular vein, then the larger spider veins, and then the little spider veins, successively in different sessions or during the same session. This is a video that media has not found, I noticed last night. I'm not sure why, but in any event, you can inject these little spider veins, and it's actually kind of fun to try to get rid of them. And there's a whole art to doing this, which is beyond the scope of this talk. You can use ultrasound-guided sclerotherapy to treat deeper and tortuous veins that are too deep for phlebectomy and too deep for visual sclerotherapy, but veins that are not straight enough for thermal ablation. So here's some examples of patients that we've treated. Here's a patient with some spider veins on the back of her leg, and here she is after liquid sclerotherapy of a very dilute drug called sodium tetradecyl sulfate, a very dilute concentration. At 3 years, they're completely gone. Here's that same patient with that reticular vein and all those spider veins, and you can do a really good job with that kind of patient. Here are some pelvic-derived Varicose veins, symptoms are only in the leg, have no pelvic symptoms, even though we know it's pelvic venous insufficiency that's causing it. These veins can be treated very easily with sclerotherapy, and there's no need to have to do any kind of pelvic intervention, which would be overkill for this particular patient. She'll probably run away from you if you bring up the concept. Here is a patient with small saphenous vein reflux and varicose veins. This is a combination of laser and then staged sclerotherapy, and eventually get a good outcome. Again, same thing, endovenous laser of the inflow, and then sclerotherapy of these enormous varicose veins, which I would do phlebectomy on now, but you can get a very good outcome with sclerotherapy. Here's a patient, this is probably soon postpartum, with multiple large veins, and then lots of these very typical pregnancy-related spider veins, and this is her after a combination of laser and sclerotherapy. Here's a patient again with laser and sclerotherapy. Laser and phlebectomy, this is 1 month. I like phlebectomy because it's efficient. You can get rid of almost, the veins are in one nice long pattern. You can get rid of them fairly quickly, and so in the background of her freckles, you can even see the skin mix 4 weeks after the procedure. Here again is a laser and a phlebectomy, small saphenous vein, varicose veins, small saphenous varicose veins. You can see the dark little freckles still at 1 month. This is an Asian patient, and her skin, like many Asian patients, shows skin marks for a little bit longer. Here's the laser and phlebectomy 4-year follow-up. You can see the varicose veins up here. The varicose veins come down around here and go around, and you can see how good they look at 4 years. So in conclusion, chronic venous disorders are common. Among the most common disorders of any kind that we ever see. They do require accurate diagnosis. Many of them can be treated minimally invasively and pretty simply. And as I pointed out before, IRs are well prepared for this. We can really do the total vein care. We can become really good at superficial disease. We can become, and many of us are, really good with acute and chronic deep vein disease, and we can get very good at vascular malformations. And I'll tell you, I'm a part of the vascular venous community, and there are very few doctors, and I'll include myself in this. I don't do all of this well, but there are very few doctors who do all of this well. But those who do all of this well are really the penultimate vein doctors, and you can take care of anything. I think as time goes on, this niche of venous care is going to become a very dominant part of many specialties, and I hope to keep it as part of interventional radiology in the future. So I encourage your interest, and thank you for your time to listen to this. And I think we have 5 to 10 minutes more, so I can open it up to questions, or questions can be handled through Claire by chatting with her.
Dr. Khilnani, thank you for such a great lecture. That was really informative and inspiring. One question that we had is, what is your routine follow-up after an EVLT or sclerotherapy?
Some patients after EVLT, or some doctors after EVLT bring patients back at 3 days, 2 days, 3 days. But I think that was really the result of a clinical trial that Venous company, now owned by Covidian, who owned the radiofrequency device, had in their clinical trial just because they didn't know. The laser trials also had early follow-up, but the incidence of saphenofemoral and saphenopopliteal junction complications were really low, and so the laser group quickly moved to follow up at some longer duration, which is what we use, which is 1 month. In patients who I'm worried about, let's say protein S deficiency, and I'm prophylaxing them with Lovenox while I'm doing the procedure, or they had a history of DVT in the past, and although their deep veins look good now, I'm just a little worried. I might bring them back at a week just to make sure they don't have one of those EHIT type occlusions, or they don't have a different kind of deep vein thrombosis, which is really rare, like a gastrocnemius vein thrombosis or something. So in general, a month after laser, and I usually bring patients back at about 2 to 3 week intervals for sclerotherapy. So every 2 to 3 weeks, they come back and do a little more sclerotherapy and or removal of trapped blood.
Great, thank you. Does anyone else have any questions? Feel free to unmute yourself and speak up if so.
I see a couple of messages coming directly to me, so thank you for thanking me. I saw one go by at least.
All right,
How many
well,
people? Claire, how many people did we have log in?
I counted 26 at one point.
Oh, good, good.
Yeah, so it was a great turnout. So thank you, everyone, for logging in and listening. And we'll post it. We'll get that information out to where it's posted. So if you know people that wanted to listen and weren't able to, they'll be able to watch at a later date. So thank you so much, Dr. Khilnani. This was a great talk. So
all right,
really,
thank you.
Really appreciate it.
All right, everybody. Thank you and good night.
All right, thank you. Have a good night.